Okay. So good morning, everybody. So lovely to see you all here on a Sunday morning. So I'm just going to quickly do a round of introductions. I guess most of you all know who we are, but in case you don't. So Ushma and I are physiotherapists, pediatric therapists. We both have studied and worked in the US for varying number of years, and now are back in India. Ushma does primarily outpatient work with I guess preschool and not too many teenagers, right? Or a little bit of the younger age group. I primarily work in the NICU and follow-up care, early intervention, so we kind of can cover a range of ages and conditions and things like that. Also, the reason why we started these mentoring sessions is because we realize a lot of times when we interact with therapists, with other therapists, there is a huge disconnect between what we learn and how we implement that. And so during many long conversations, what we realized is the reason we work differently is because of the beautiful mentoring we received throughout our careers. And again, the exposure to a different system where the focus is on efficiency, the focus is on outcomes, the focus is on function, the focus is on independence, and in whatever capacity the child can achieve. When we talk about independence here, it automatically becomes this thing about walking independently or talking independently, and that's not what we mean by independence. Even if the child needs an assistive device, what can they do so that they are able to live a full life, within their capacity? So that's the reason why we started these, sessions, and we are very happy to see so many people joining to listen to us. The one thing I do want to mention here is that mentoring is different from a formal workshop on a particular topic. During these sessions, we want to offer you different perspectives that you may not have access to where you're working, or if you're still a student. So the purpose of these sessions is to open up these kind of ideas to the audience, and kind of help you think in a certain way, or direct your thoughts in a certain way. We are not giving templates, we are not giving this is not a case discussion. Okay, we are not taking any particular case to say this is what you do for this. We are not discussing algorithms, protocols, any of those things. All right, so I hope we are able to make that clear when we begin, because I know at the end of the session a lot of times the questions come to us specifically about a case which we are not going to answer or discuss. All right. Okay, so Ushma, would you like to begin?
Yeah, sure. Thank you, Pooja. Thank you for the, starting with a great introduction. And here I just wanted to add one more thing to Pooja. Pooja, what she said, I absolutely agree with her. And I'm adding one more thing that recently on Facebook, I saw some post. I don't know whether it was from India or whether one of the countries from Africa, I don't know. But the post actually said that don't recommend a walker or an assistive device to a child or an adult. Physiotherapy should ensure independence. And I didn't say anything to that post because, arguing on social media is useless at many times. But basically why I brought it up here is independence doesn't mean absolute independence. The purpose of why we do therapy, why we treat children or even adults, or why we give a cane or walker or, so on and so forth, is to achieve the maximal independence according to that child's potential. Okay, because think about it, we have been practicing therapy for decades in India, 5 decades, I know, and even more decades in the Western countries. Why are we still having people around with disabilities? If we could, so, what that person meant is don't give a walker. Physiotherapy should ensure independence. He's actually meaning a cure. And you have to keep in mind, we cannot have a cure. Cure is not the purpose of therapy. So many parents will ask you, oh, then why do all this therapy? Why this effort? Why the money, etc., etc. What I would tell that parent is, think about what would happen if the child does not get therapy. That is my simple answer, particularly for that child. Okay, not to scare the parent, but just to have a very polite conversation that if this child does not get therapy right now, right at this time, right time, then what happens to the child? Make the parent think rather than, answering them everything, get the parent on board. So this is what I wanted to, say. Because this post really blew off my mind. Okay, I almost wanted to fight with that person. I don't fight with anybody, but I'm like, what are you thinking while writing this post? So, let's get to today's topic is documentation. And, we'll get started on this. Now, again, here, documentation also, I have put it here, the way I do it. Many of the topics or the subtopics of this documentation can be interchangeable, here and there. Pooja has also added 1 or 2 slides, thankfully, she will also jump in with her comments. Documentation is also not done a particular way. Every therapist has their own style of documenting. Plus, every institution or organization that you're working in may not provide you the time and or the money. Remember, time is money. Okay, time is money. You take 1 hour to evaluate a child, 2 hours to evaluate a child, or you call a child twice, for an evaluation, which is fine. However, always think of time is money. So, and who is going to pay for that money? Is it going to come from the organization of the institution? Is it going to come from the government? Is it going to come from the insurance? Is it going to come from the parents' pocket? This is a whole topic of economics in physiotherapy on which I have written a paper, which got me thinking, many years ago. But you have to think, where is the money going to come from? And, the thing is, at the end of the day, you don't feel, oh, I spent 2 hours in evaluating this child, as Ushma ma'am said, or Pooja ma'am said, and I didn't get so much money. That should not be the case. Or even treatment, I did not get so much money. We all need money to survive. So, you have to think along these lines, economics in physiotherapy, think about economics in physiotherapy. So the outline that I'm going to share here, yes, I take a lot of time. I do charge also proportionally to the parent. I take the time also because it's my clinic that I own. Even in the US, when I used to work, I used to do it like this. However, you have to conform or modify this style of evaluation to your needs. And again, I would, end by saying that even if you don't evaluate the child fully, if you're just evaluating the child superficially, still make your own progress notes. Get into a habit of making your own progress notes, paper and pencil, the older way, or nowadays phones have recordings. So sometimes I even record, very quietly into my phone, this child, this date, did this is what I saw. And then I'll later translate it into, digital or whatever. You people are young, you're much smarter in doing that. So, but always keep notes on every child or every person you see. That helps you a lot. Okay. So let's get to this documentation in pediatric PT. Today, we are only going to talk about pediatrics. So why is documentation? What is the purpose? Why do you do it? It is a mandate, particularly in Western countries. It is definitely 110% mandate. In the
Ushma?
US, yes.
Do you need to share your screen?
Do I? Sorry. I'm sorry. Thanks for reminding me. Share screen. Huh? Okay. I just opened up my PowerPoint as I generally do. And can everybody see my screen?
Yeah.
Maybe I need to fully blow up, I guess. Yes. Can everybody see my screen, right? If not, yes, you please write in the chat box. So documentation in the Western countries is 110% mandate. There we believe that if you have not documented, you have not done your treatment. That is it. The sentence says it all. For me, documentation is to establish a baseline as to what the child presented, how the child you saw in what way when the child first came to you. So establish a baseline, no matter where the child has gone for therapies before, but when the child first met you, let's say today, what is today, how the child looks to you, that is my baseline. It serves me as a record. Okay. And then documentation done monthly, quarterly, yearly, whatever it is, it reflects on the progress with therapy. Even if you do annual or semi-annual, I still write down notes as and when I can. As I said before, I write down even a 2-liner note. Today the child did this, or today the child did not do this, or today was, communication or behavior, I had this problem. I do write that down because then I can consolidate all at the end of the year or the end of 6 months later. Now, so then, it reflects progress. Now, and then learning and reflection. So as a continuation, when you take down your own rough notes and you translate them digitally into your laptop or wherever, it is actually a learning for you, a reflection for you, because to come back after 2 years and 3 years, oh, this child looks like child A whom I saw 2 years ago or 3 years ago. And, it's a constant learning, reflection. And therefore, documentation is very important, because if you have not written it down, you forget. Evaluations. Great. So, you start with very basic, the demographic information. Name. Again, make sure you write the child's full name, surname, initial, whatever it is, and spelled very correctly, because I see a lot of reports where there is the name is spelled wrongly and the date is not even written. Today's date of the evaluation is not even written. So now imagine if that piece of paper goes somewhere else and then the parents forget, oh, when did we meet Dr. Ushma? Oh, we don't know, it must be on the report. And if I've not written the date, just think what happens. So name spelled correctly, full name, initial, the gender, the date of birth, and then from the date of birth, you get the child's age. So in pediatrics, generally we write in, let's say 3.4. So 3.4 is the child is 3 years and 4 months old. Now, up to when do you do it? That's a little, I sometimes do it up to 7 or 8 years. That's it. After 8 years, I just say 8 years or 9 years. If I see a little older child, at times. But that is up to you. But age, and then corrected age if applicable, if the child is preterm, at least till, I guess, 2 years or 3 years, you want to write in months. So let's say if a child is 3 years, is 36 months, but the child is 5 weeks premature, then you can write corrected age is 31 weeks. 36 minus 1, whatever. Please, Pooja, come in that. Please
you only correct the age to up to 2 years.
Great.
And so it is the number of weeks. So generally what happens is, if you look at the discharge summaries, if the baby's preterm, there is weeks and days as well. So, if the child is, say, 31 weeks and 6 days, right? So they do give that consideration about the days as well.
Yes.
But again, when you're calculating adjusted age, we don't really look at that. Ideally, we should, but we don't, because it's very difficult to, manage that calculation later. So generally, if you ask a parent, they will say something like, oh, the child was born in the 7th month. But 7th month means exactly when? There are 4 weeks in a month, right? So make sure that if the baby is preterm, if you know in advance that the baby is a preterm baby, you're going to evaluate, make sure to ask the family to bring their NICU discharge summary so that you can know exactly how preterm that baby was. The other thing I would also say in terms of correcting the age is, again, that it is critical, especially if you're going to run a formal standardized tool for an assessment. Make sure that you do adjust the age correctly and not just do 7th month, so that's two months or 3 months short, because the cutoffs for each of these ranges can be very different. So -2 standard deviation can look very different just from 2 months to 2 months 1 week. So make sure that you do use that what do you say, the exact number of weeks that the baby was preterm. The other thing I want to say in this is that 37 weeks and up is not considered preterm, right? So if the baby is 37 weeks, or 36 weeks plus say 5 days, that baby is still a preterm baby. And for a preterm baby, you consider 40 weeks as full term. Even though the range of preterm is between 37 and 42, the range of term is between 37 and 42, anything less than 37 will be 40 weeks is used as the number of weeks preterm. So for example, baby is 35 weeks, right? So how many weeks preterm is the baby? 5 weeks, because you consider 40 weeks as your end range. If the baby is 33 weeks, it is, 7 weeks, so on and so forth. Got it? Okay.
Great. Yeah. So I also, the corrected age generally, or adjusted age, in India, people write, we write corrected age sometimes in the US. The thing is, 2 years, I agree, because beyond that, there's no point in really sort of, writing that on your documentation. However, you have to keep that in mind, because then it has a lot of sensory and motor repercussions. Baby who's born preterm, baby who is, again, very low birth weight, has a lot of issues in future, we see. Because parents will generally tell you that, oh, everything was fine, he was a little late, he or she were a little late, or achieved a little late, maybe 1 or 2 months. But however, we see a lot of repercussions in the functional performance in future, highly likely, again, not that every baby will go through that, but highly likely. So that's why that the history, the preterm is very applicable. Okay. Today's date, whenever you say, I said, don't let your report go out without a date and a correctly spelled name, because it is going to reflect very badly on you as a clinician. I also write down parents' names who are present. Okay, sometimes only the mother comes, sometimes mother and father both come. I write down both their names. And then obviously the record number is your own, or the institution or organization, just to keep track of how many children you saw per year or something like that. Now, here the general information or the background information is very important. I generally start. Now, pediatric reports, particularly in physiotherapy, occupational therapy, and speech therapy, are narrative. And that's why they take longer to type or write them down. And believe me, today you're typing. But 30 years ago, I have actually written them down, even in the country like US. Okay, I did not have a computer or a typewriter then, back in until the mid 90s. So we used to handwrite reports. So, I just generally I start, your starting is important. It reflects on what you did. So, XXS, is basically so and so is a how many years. So we went through that in the age, right? That 3.4 years or 3.6 years, or you can write 3 years and 3 months old boy or girl. And this child was evaluated in the presence of only mom or in the presence of both parents. Okay. So since I deal more with preschool, I do deal with babies, not as much as Pooja does, but still, if they are attending a school currently, then I write down, they are attending nursery class in a local preschool or whatever, or a Montessori style school or a special school. And then at this time, they are receiving therapies, because children generally nowadays, parents are known to hop from clinic to clinic, particularly in Bangalore. So I generally take down what are the other therapies they're receiving. They're receiving ABA, speech, whatever, etc., etc. And then all this information for this evaluation has been collected. How are you collecting all the information that goes into your evaluation or consultation? You are taking verbal reports from parents. You are doing your clinical tests, observations. You are doing standardized tests, maybe whatever you're doing from here. I also have my own screening form, which I used. I have designed it to make life easier for me. So I write that also, that, the screening form. And then mode of referral becomes important, for many children that I see. How are they referred to me? Have they come to me through the internet? Have they come through me to a teacher? Have they come to me through some other parent who attends my clinic? Have they come to me through, a doctor, for example, a developmental pediatrician? So whatever, the mode of referral. And then the first thing I ask every parent is, what are your concerns as a parent for this child today? So parents will generally say, oh, delayed speech, or the child is hyperactive, or moves around a lot, or has eating issues, or eats only so many foods. So, I write down 3 or 4 concerns over there, that what are the top concerns of the parent right now. And since the last 4 or 5 years, I've started adding screen time to all the children, because I find that children are given screen for prolonged hours, right, since the age of 6 months, 8 months, that is in the first year of life. So even if a child is now 4-year-old and has had a history of screen time for 6 to 7 hours per day since 8 months of age, I do write that down, because that gives me something else into my clinical reasoning. Okay. And then I also write, but now parents have discontinued, or now it has been minimized, so you take down the history, whatever it was. And then also, parents will generally say, oh, now, we have reduced it a lot. So how much have we reduced? Oh, we only give during meal times, or we only give during night times for 1 hour. So I write that down also. And then the child, whether lives in a nuclear family, extended family with aunts, uncles, grandparents, they have a sibling at home or not. And, and then my very important question to parents is, because I see children 3 years and up, when the child is free, when the child is, nobody's occupying him, what does the child do? This is a question, and that gets parents thinking. They answer me things like, oh, you know what? He just runs around at home from one room to the other, or he jumps on the bed most of the time. Or sometimes I will say, oh, he can play blocks for about 5 minutes and then run away. For our children who are very dependent, CP children, or sometimes Down syndrome children, just to bring in a few diagnoses here and there, how do they spend time, in what position do they spend time? Because that's an eye-opener. Children who fall into the classification of GMFCS, 3 and below, sometimes the parents will say, oh, they're only lying supine like this, so that gives me something to think about. The child is lying supine and staring at the ceiling, doing nothing else, which means there's no stimulation. So, right, I have a goal there to work on, get the child into a sitting position or a semi-inclined position, or whatever. But when you take down all this history and all this information, you start working on, you start thinking on, what are you going to work with this child first, top priority. Because imagine a child who's just supine, and I have many children like that, who I see on a 1-time or 2-time consult basis, and even at age 5, they're just on the floor like this because there's nothing else to do. So what do you do with such a child? I get the next step, how to guide the child, how to guide the parent, educate the parent, the change in position, and then how the change in position will bring in the stimulation. Okay. So this is general or background information, whatever you want to call. History taking, again, little important. Don't spend too much time, but even when children are older, I do try to see whether they are born through C-section or normal delivery. There is a reason why I do that. Birth weight, because it gives me, insight into whether the child was low birth weight or even very low birth weight. Developmental milestones you can prolong as much as you want. For 3 years and up, I only see turning on belly, crawling, sitting, walking. Crawling here I mentioned importantly, because I'm very interested in crawling. I do a lot of work in crawling, and I ask, how much if the child attained crawling or not, and if they did, how much crawling they did, because some parents do answer me, only they just crawled for a few days and then started walking, or they only crawled for a week and then started walking. And then my brain starts thinking that the child is highly likely to have bilateral coordination issues, vision issues, etc., etc. So that's why I always ask, crawling and for how long. Now, again, as I said, developmental milestones, if they are a baby, if Pooja is looking at them, 2 years and below or 1 year and below, they are going to go into a much more detailed, and then this history will not be history. This will become actually a part of the main evaluation for younger children. So that's why in the beginning of this session, I said that parts of this, what I have put here, they can be little interchangeable. So, baby between below 2 and particularly under 1 year of age, these developmental milestones will become a huge section in your current clinical observations. It won't remain a history anymore. Am I right, Pooja? Yes.
So yeah, like you said, it depends. For the infant, especially, they've come really early on. That means there was a lot of, lot of things that have already happened in terms of their birth history. So maybe preterm birth, or even if they are full term, they might have had an NICU stay, or even some things like a lot of fussiness, a lot of crankiness, feeding issues,
Yes, latching on.
Right.
Even if they're older children, I do ask for early feeding issues as a newborn, meaning did they have issues latching on to the breast? Okay, so I do ask them even if they're older and they come to me. Yes.
Right. So I still would put that under the birth history in that sense.
Okay.
Okay. Because there is a lot that we could gain, a lot of insight that we could gain, like were there surgical,
surgery,
issues,
yes,
maybe the or are there, say, congenital, say heart conditions that are not resolved right now, but again can affect how you work during your session with this infant. So there is a lot that will fall under birth history if it is an infant.
Yes.
To me, because again they come to me so early, the developmental milestones, like you said, they do fall under the actual observation.
The main part of your evaluation. Yes.
But in the birth history, all of these things get added for me.
Great. So again, as in the beginning of the session, I said, I want to clarify again that the subtopics that I have arranged here, myself and Pooja, you can interchange them depending on what age the child is being seen by you. And right now, whatever happened before, the child came to you probably goes into history, but then you have to write it down. You have to ask the right questions because it has a lot of bearing on your treatment. Like Pooja said, that what if they have some cardiac issues? I've had Down syndrome children, my antenna goes up. Oh, do they have cardiac issues? Because Down syndrome children are highly likely to have cardiac issues, and I would have that at the back of my mind. And then I ask parents, have they been seen by a cardiologist, a pediatric cardiologist? If they have seen, when? Some parents will say, oh yeah, pediatric cardiologist we have seen. When? 3 years ago or 2 years ago. So, this time, the information and the time. So that would come in the medical issues, that I have put here. Seizures is my biggest antenna coming out. I want to know if the child has had seizures, at what age, how many, how long, what are the medications given in the past, in the present. I want to know all of this because then it will have a bearing on my treatment. And then any diagnosis. So to me, I try to ask, who, if it's a diagnosis of GVD or cerebral palsy, it's highly likely that a pediatric neurologist has done that, or autism, hyperactivity, a developmental pediatrician. So I write down the doctor's name and who they are. And if there is no diagnosis also, don't worry. I write that in the clinical impression, which is the last or the second last part of this evaluation, that there has been no diagnosis yet, but the child presents with this. So history taking, this is what you do. Now
I just want to add one thing in the history. A lot of times, especially, like I said, for infants, a lot of the history can be found in their discharge summaries. And what I notice is a lot of times therapists will just copy it from there.
Okay.
So please know it's not meant, like, you don't want to waste your time repeating information that already exists in the discharge summary, right? So to me, I think when I'm writing a report, I want the person reading it to understand a therapist's perspective on what has happened, right? So I don't want to know like medication, in the sense that unless it's a medication that's going to continue and affect, like for example, seizure medications, right? So they do impact how the child's regulation is, how their child's arousal is. But I don't know, like vitamin D, like there are certain things that you really don't need to copy in your
Yeah,
summary.
I agree. Don't copy everything from the previous documents, rather than try to reflect on your own. So I put seizures there because, and medications there, children who are on anti-seizure medications for years, let's say even 3 to 4 years, they're highly likely to have osteoporosis. It has a medical repercussion when you do your positioning, handling. Obviously nowadays I don't do stretching. I don't know who does, but if you are doing any stretching, then that osteoporosis will matter even when you are measuring for a brace or something like that. Okay. So
yeah, so that's what I was trying to say, that your birth history, whatever you write there, you have to connect it when you write your clinical impressions or you're writing your goals, So make sure that it's not a disconnect. Like when someone's reading it, like you're reading a story, your introduction or the explanation of the main, characters, that is the impression that, you take throughout to the end of the story, right? So, the purpose of documentation is not to waste your time and energy in just doing what something else has already been done.
Correct.
Offer your perspective, why, again, if I'm a medical professional, I don't understand what a therapist can do with this kind of information, right? But in your report, even if it's just 1 or 2 lines, like you talk about in your goal writing or your impressions about, the child has a history of 1, 2, 3. Therefore, my goal will reflect these things, or we will need to look at these things in the future, whatever it is, But that is the critical thing about, writing a report from a therapist perspective. In my opinion.
Exactly. Thanks, Pooja, for adding that. So now, if you see this slide, systems review and then clinical measures. Now, these are the way this is arranged is according to the APTA recommended style of writing evaluation. I have been doing this since, I don't know, last 20 years or even longer. And that's why I put it here. But you can come up with your own style of documentation if you want to. Just make sure that it reflects what you're trying to say. So in the systems review, I go through 4 or 5 major systems. One is behavior and communication, and then musculoskeletal, neuromuscular, and so on and so forth. Now, it doesn't have to have everything here. Like I generally nowadays I skip the musculoskeletal as long as there are no contractures or deformities. I skip the integumentary if there are no scars or anything. Sometimes I combine the two, the neuromuscular and the musculoskeletal, meaning I write it as neuromusculoskeletal. That's what I write the subtopic as. So it depends on you what you want to do. But behavior and communication, again, I used to write only behavior earlier. Now I also write communication. Even if a child is non-verbal, I try to reflect, whether the child followed my commands. If not my commands, did child follow mother's commands or parents' commands, or eye contact. It's always different with mother and with therapist, particularly during the evaluation. This is the first time that you're meeting with the child, so the child is highly likely to ignore you. How did eye contact improve as the evaluation went forward? These are all the things. And then engagement. So as soon as, this is the way I write that, the child just walked into the therapy room and went to the swing, or the child walked into the therapy room and would not sit on the floor mat despite being, encouraged by mother, or the child would not do this, or would only child was immediately attracted to so-and-so toy and started spinning it. This is how I write the engagement part. Okay, engagement. What was the first thing you did, or the child did by themselves to engage, build that connect between you and the child and your place, because remember, this is a new place for the child. So everything is going to be very different. So in that behavior and communication, I write all of that. And even if they are a non-verbal child, did they do any gesturing or through body language? Did they try to communicate anything, like pushing away or pulling things? Or I do write all that. Musculoskeletal, as I said, if the child has deformities, contractures or tightnesses, then I would record that, whatever it is, -8, -10 of dorsiflexion, or I write that range of motion down. And then here I would also write if the child is using braces or splints, daytime, nighttime, I write that down. Neuromuscular, you can write about the muscle tone. You can write about, the spasticity or Ashworth's, modified Ashworth's will come into the neuromuscular. And then cardiopulmonary, generally I write if the child has any cardiac issues, and even if not, do they have frequent colds and coughs more than what generally children have? Okay, I do write that down because it has a bearing on my treatment. And then integumentary, if there are any integumentary issues that you observe, old scars or old, and something that has an impact on your treatment or on the child's function later. So very briefly, systems review is very brief. It's not very long. If I'm testing core stability, I do get a lot of children with handwriting issue. For me, their core stability becomes very important. So I have certain standardized tests that I follow to measure core stability, that I put it into the neuromuscular. If you want, you can even put, so no, strength goes into something else. But yeah, this is what I do, systems review. Can I move on, Pooja? Is this fine?
I just wanted to add for the behavior and communication. See, our, evals, they happen. So it's the first time, or the first 2 sessions are usually assigned to, run your evals and assessments, right? And so a lot of times, the child does not really, the performance does not reflect their ability, So I always, especially for behavior and communication, because the other systems, they are very, what do you say, like Ushma said, if the scar is visible, it's visible anywhere, So certain things are very obvious that whether the child can do or not, but certain things that are performance based, that are behavior based, can be different, once the child settles in, gets into a rapport with the therapist. So for me, and especially because I work with infants, they usually are not very, what do you say, they don't regulate themselves very well if they, are not happy where they are. So I will write during the session, this is what I observe. And then I have a little paragraph at the end where I say parent reports. That is what the child usually is.
Yes.
Home,
Yes.
So then I kind of also, not only for myself, but I always feel like when a parent is reading a report, I want them to remember that this is a one-time snapshot, It is not the movie. It is not the continuum that, we are writing about. And I try to, what do you say? Like, my hope is that they don't get too dejected, because we have to be honest in writing, what they can and cannot do. And most of the times there's a long list of what the child cannot do, and so I don't want the overwhelming feeling to be that, oh my God, there's so much we have to work on.
Yes. Also, look at the strengths, what the child is. I put that later, but also look at the strengths. So I agree with Pooja when I write that, as I said, the child did not follow therapist commands or did not connect with therapy staff, but, played with the parent and offered this toy or that toy. That is what you saw. So, everything is basically in contextual, whether the child does this with you or did not do this with you, but did with the parent. Okay. Sometimes, another child walks into the room because the time is up and everything, and the child goes and reaches out to the other child. So I even write that towards the end of the evaluation, it was observed that this child tried to connect to the other child, through whatever communication, sharing a toy, etc., etc. So everything can be expanded or narrowed down, but make sure that you also put some strengths, into the report. Can't overwhelm parent and can't scare them. That's not a very good feeling. All right. Clinical measures is basically, so again, I'll go first to the gross motor, fine motor. Gross motor, fine motor. Fine motor, you don't have to if you are not a sensory motor therapist. I am, so I do it. Gross motor, you can either follow standardized test, or you can find many just milestones on the internet, and you can come up with a list on your own as to jumping and, stepping over an obstacle, jumping from a surface, jumping in place, jumping forward, jumping backward, jumping sideways. However, it's not just checklist. Make sure that you understand as a therapist, and parent also understands that this is not a checklist. Number one thing is whether the child can do or not do. That is number one. And if the child can do, the biggest thing is what is the quality of movement. So jumping in place, for example, the parent will say my child jumps, and the therapist also feels the child is jumping in place. Are they clearing the feet off of the ground? If they are jumping from, let's say, 20-inch surface, do they need one hand held, or do they need very minimal assistance, one finger, or they don't need that, but they reach out to you, the first time. But then second time, third time, if they are better, again, we don't test 10 times because then the child will get mad at you. But, at least 2 or 3 times you need to, or balance beam, walking on the balance beam. Does the child reach out? Did they have truncal sway a lot? Did they have high guard? Did they have medium guard? Did they have only high guard on one side versus the other? So all this quality of movement is very important. When you check single leg balance, we check, it comes either in the gross motor, or you can even put it in the vestibular system. That is after this. Child stands, parent will say, oh man, he stands on one leg. I do yoga with my child. And I'm like, how? Yes, the child is hooking. You know what hooking is? You stand on one leg and the other leg is touching the other knee. Basically, both knees are touching each other. There's no space between both the knees. That's called hooking. Or the child has too much truncal sway, or the child is doing this. So quality of movement. For me, quality of movement is more important than actual skill itself. And this is where therapists also have to be very skilled in not only observing, testing, but also conveying to the parent that it's not checklist. I'm not only checking checklists. Okay. Posture and mobility. So mobility, how the child is walking on floor level, how the child negotiated, from floor to 1-inch mat, because sometimes the child will just walk into the clinic and fall on your mat, fall over, because they came against a, from a floor surface to a mat surface. Now, do they have a balance issue, or they can't see enough, or they were too much in a hurry, whatever happened? But, can they negotiate that surface? Stair climbing can again be gross motor, or it can be mobility. It's up to you where you want to put it. Stair climbing also, was it reciprocal feet pattern, non-reciprocal feet pattern, one hand held, 2 hands held, whatever. You have to, dice it down to the information that will help you in your treatment. That's the whole purpose of this documentation. And the biggest part is posture. So posture with children who have, cerebral palsy or Down syndrome or those neuromotor disorders is very easy to observe. It's very difficult to observe in children with autism. And that's what I write. They have excessively pronated feet, they have excessively anterior pelvic tilt, they have excessively genu recurvatum. All this tells me about muscle tone, even without touching the child. And therefore, I observe this. Again, low muscle tone is again another topic by itself. Physiotherapists, we are very good at testing spasticity or rigidity, but we are not good at testing, low muscle tone. And we need to do that. We need to learn how to observe that low muscle tone, observe or test low muscle tone. Okay. Posture, again, if you can, how do they rise from, in posture or in mobility, you can say, or sometimes I combine both posture and mobility together, and I write floor to stand transitions or floor to sit transitions, meaning the child is on the floor supine. And how did they transition to rise to stand? Meaning, did they use a supine flexion, or did they use a half kneel, or did they use some furniture to pull over, or did they ask the parent to, give them a hand? All of this I write down. Transitions, very important for me. And then sensory is a whole major, all the systems that I test or I see in sensory, there is a big thing. Vestibular, there is proprioception, tactile, oral motor, visual, auditory, interoception. That is a whole section by itself, sensory. So in my evaluation, all of that goes. One more thing I forgot to mention is reflexes. So reflexes you can put either in your systems review in the neuromuscular section, or you can put it here somewhere, reflexes, if you really see them. Now coming to reflexes, ATNR, STNR for babies, it's very easy to test and see. However, the population that I deal with, 3 years and above, most PTs do not know that we don't test ATNR, STNR in that way, the head turns and the upper extremity extends. No, we test them in the quadruped position. How they look like. So again, you are taught that generally textbooks teach you that reflexes, they get integrated. No, they do not. They stay with you throughout life. They appear whenever you are in a stressed out position. They appear when your motor patterns, the person or the child has not developed skilled motor patterns. The ATNR, not like the ATNR, not in full measure or full blown, but in small measures, you can observe it in different positions and postures of the child. You have to develop that skill in doing that, and that's why you need mentoring. You need mentoring in pediatrics. Okay. So now the last part of this evaluation is very, very important. This is the part you can call it assessment. Earlier, I used to call it assessment. Then I started over the years, I started calling it clinical impression, meaning everything that I've seen so far, what is the impression can I make? And as Pooja said earlier, your report should reflect what you saw and what you understand about this child. It should give you a holistic view or a whole picture about the child. You cannot copy someone else's report or repeat what someone else has said. So I generally put it on, again, I repeat that so-and-so child, so-and-so is, because you're writing an assessment again, Ajay, for example, is a 3.4-year-old child evaluated in my clinic. They have come to me because parents are concerned with this, or the teacher has so many concerns. Or the doctor has sent to me, or if the doctor has not sent to me, there is no formal diagnosis yet, because 80% of the parents has come to me directly. So there has been no diagnosis or nothing. Nobody has been seen them except the regular pediatrician who gives them vaccination shots. But parents have just come to me because someone else has told them, or they have surfed the internet and found out a few things and are concerned. So I said there has been no formal diagnosis yet, or there has been no formal medical diagnosis yet. But this is what I saw. So I do write down strengths of the child, weaknesses of the child, and then what are the clinical concerns to me, that are glaring. W sitting, low muscle tone, delayed speech. Why delayed speech? I'm not a speech therapist, but still, why delayed speech is a concern to me? Because through my sensory motor intervention, I can have a positive impact on speech. Okay. Or in the whole picture of the child, communication has an important role to play. Therefore, I do mention that. And then if you're doing any standardized test, you can, put out scores over there. And then why would this particular child benefit from therapy? You have to write that in the, like a paragraph to that the child has, these oral motor issues, the child only eats this, or, the vestibular system is underperforming, or motor skills are far below age appropriate. You have to write a paragraph on this. And then you write the goals. And then the last is plan of care is, the frequency of therapy that you plan to see for the child, 2 times a week, 3 times a week, whatever it is. Duration, is it a 30-minute session, or a 40-minute session, or a 1-hour session? And then are you going to see the child one-on-one basis, or in a group of 2? Strategies is something that, other professionals expect from us. I don't write that too much because I do so much of evaluation. I spend so much time that I just can't give strategies. And strategies that are given by, doctors or maybe other professionals, I generally, in my experience, I see that they are just general information cut, copy, pasted. So I refrain from giving only general information. If I'm giving strategies, then I'll give it for this particular child, individualized to this child. If not, then I will say I'll see them for another session and then provide strategies. And then additional recommendations, school enrollment. So many children are out of school. So I highly recommend that school enrollment in near future, where the child will benefit from swimming or speech or, any other therapy that you would like the child to be in. And even other consultations. If the child has not, seen a pediatric neurologist or a psychiatrist or a developmental pediatrician yet, I do tell the parents right the first time that, please in the next 1 month or 2 months, make a plan to see a medical doctor who specializes, in seeing children, and see what the doctor has to say. And, this is what I write. I think Pooja has written, so daily notes, right? That's a topic, right? So in daily notes, roughly you can talk to the parent and write down as to what, Pooja, this is yours. Why don't you talk about this?
Hi. Sorry, I just got disconnected.
No, sorry. I just went on and on, but you can go ahead.
No. So, documentation is not only what you do in your evaluation. Every, visit that you have with the family should be documented. And so, I think you need to go back to the slide, Ushma.
Yeah. I lost somewhere.
Okay, but I can just, quickly run through. So your daily session notes, should include at least 3 sort of sections. The first section should be a little bit of, an update, so to speak, about what has happened in the time between your last session and this session at home. So every time, the parent leaves, you are going to offer them some things to do in the house, right? So did they do that? Where they struggled, to do those kind of activities? Did they see any, change in their routines because of the activities that you have suggested to them last time? Sometimes that they will just come back and say we just couldn't do it for whatever reason, right? So just note it down that carryover did not occur in this week. So for me, I do not see the child for more than once a week, right? So there is a 1 week gap in between 2 sessions where the parents practice a lot of things within their routines. So for me, it's very critical to understand what that week looked like for them, so that I can change my handling of the baby or the suggestions that I offer them, accordingly. Then the second part that I always sort of, discuss is what activities you did. Now, again, a lot of times, you will see that maybe I just say, tummy time, or, some like just a bullet point of whatever the activity was. But the first time I write something, like if it is the first time that I've introduced tummy time to them, then I will write, the whole, almost like a write-up about what tummy time is, all the advice that you gave along with that, so that the parent has that as well when they're looking for, information on what to do at home for that week, right? And there is a little bit of, again, what my impression was that, I put the baby on the towel roll and they did better, versus I put them on the floor and they, didn't appreciate it so much. Just again, your impression of where the baby is. And then the third section is always a home program. I always give not more than 2 or 3 at the most activities that a family can do within their routine or within the playtime that they already have going with the child. So for example, every time they pick up the baby from nap, right? The baby is asleep, they're on the bed or whatever, and they're going to get lifted up off it. if I'm working on, say, shoulder strength, or I'm working on, weight bearing on the palms, then I will, encourage them to roll the baby over on their tummy and get into that hands and knees posture, and then twist and sit, and then lift the baby up, right? And of course, we have worked through these components throughout the previous sessions. But my point is that there is always something that they can do within their routines. I do not advocate for any strategies. There are some things that have to be different. For example, say when you're sitting and, trying to get the sitting balance going. So obviously that's not a routine, but that is part of their play. They are sitting down to play with their child. So this is how you're going to modify how you're going to play with your child, stuff like that. So it's very simple. And I make sure that the parent has practiced that during the session in front of me. And I know that they have understood what's supposed to be done at home. Only then will it get noted down as a home program, right? And then any other update, sometimes the parents will say something like, oh, grandparents are visiting for a few months, stuff like that. And so then I will have a chat about that. What kind of interaction do the grandparents have with the infant, and sometimes they will say something like, oh, they don't like the baby being put on the floor because the baby cries and the grandparents don't want that. So then I will say, can the grandparent do this part of, say, put the baby in prone, but over their lap instead of on the floor, can the grandparent hold the baby in prone over their arm, like the colic hold, and walk, or take the baby for a walk, or sing to them, or whatever it is. There are so many things that you can do, so that's the kind of stuff that I also like to hear from the parents about what is happening in their daily routines. So that's this, because I work with infants a lot. For the older kids, schooling, or other social activities, if they're going for some kind of class or sports or art, or, so those are some of the things that you could also, use as a strategy within your session so that they can perform better in those participation, things that they do anyway. Okay, so that's it.
Great. So I think I'm going to end this here, and we will take questions for another just 15 minutes. That's it. And we will call off at 12:15. So anybody who wants to ask a question, please unmute yourself